WFNC.
Live from Studio A at the Cumulus Broadcast House, it's Health View with your host, Dr. Angela Ruff. Your information leader for more than 65 years. News Talk 640.
WFNC.
And welcome to Health View. This is Dr. Angela Ruff, and our guest this morning is Dr. Atkinson. Dr. Atkinson was born in Philadelphia, Pennsylvania, and received his Bachelor of Science degree in biology from the College of William & Mary. He received his Doctor of Medicine degree from Jefferson Medical College in Philadelphia, where he was inducted into Alpha Omega Alpha Honor Society. He completed his internship and residency in general surgery at the Medical College of Virginia, where he served as chief resident. He then traveled to California, where he completed his cardiothoracic surgery residency at the University of California Medical Center in San Diego. Dr. Atkinson began practicing in Raleigh in 1979, where Dr. Ziuk joined him in 1982. In 1993, Dr. Atkinson and Dr. Ziuk merged. Dr. Atkinson, how do you pronounce your partner's name?
Ziak.
Ziak?
Ziak.
Okay, thank you. I figured I was killing it.
Just say it's not Xerox.
Dr. Ziak merged their practice with Carolina Cardiovascular Surgical Associates. Dr. Atkinson performs adult cardiac and thoracic surgery at both Wake Medical Center and Wex Hospital. Dr. Atkinson may consider performing heart surgery on patients whose religion does not permit the use of blood products. Dr. Atkinson is a fellow in the American College of Surgeons and the American College of Cardiology. He is certified by the American Board of Thoracic Surgery and is a member of the Society of the Thoracic Surgeons, the Southern Thoracic Surgical Association, and the American Medical Society. Dr. Atkinson is active in mission work in Russia. Dr. Atkinson, thank you so much for taking time out of your busy schedule to be interviewed for our program Health View.
Sure, glad to do it.
Super. Well, you know, your specialty is cardiovascular disease and surgically fixing these problems. Our listening audience, may appreciate perhaps what are some of the symptoms they should look out for to be a sign that perhaps they do have some problems going on.
Well, the most common things that people have, of course, when they have heart problems are chest pain or shortness of breath. Sometimes they have pain down their left arm or tightness. Sometimes people say a choking sensation in their throat.
Right.
And, of course, other things can do that, like esophageal reflux and indigestion. But one should always be cautious about, saying it's just a stomach ache when it could be something more serious. I think family history is helpful. We see patients frequently whose parents had, we say, premature cardiac disease, like a heart attack in their 40s or 50s.
Right.
They should be more alert to possibility if they're having chest pain or shortness of breath.
Right.
Or perhaps even get a stress test at age 50, let us say, or age 45 at the time their family member had cardiac disease present.
Right.
That they should perhaps get a stress test with their family doctor or cardiologist. And so, of course, probably every person after the age of 20 should have their cholesterol levels checked.
Sure. Now, I know they have this technology available up in Raleigh. I'm not sure that we quite have it here in Fayetteville yet, but the cardiac CAT scan.
Yeah, the cardiac CAT scan is useful as a screening test, and it's really a statistical test. It doesn't, I don't believe, in many patients give a high degree of anatomic specificity. If you're talking about calcium scoring and that type of technology. It's very helpful, though, if you have a low calcium score. It's highly unlikely that you have severe coronary disease.
Right.
If you have a high calcium score, it's likely that you have coronary disease, and I can't give you the exact numbers because I'm not familiar with them. But it's helpful if a person has a high anxiety level, or let's say they have a strong family history and have had some questionable symptoms, to get a test and they have a high calcium score. They probably need further investigation. If they have a very low calcium score, they probably don't have a whole lot of coronary disease, particularly if they're in the, say, 50 to 60 age group.
Right.
Sometimes coronary atherosclerosis does have, can be just fatty plaque and not have too much calcium in it. So a young person, that may not be quite highly as specific. But it's a very helpful test as a screening statistical test. But to give a specific diagnosis, does this person need to have further intervention or cath? It's not. It should be weighted with other factors in terms of statistical analysis that can only be done by a cardiologist and or a general medical physician.
Well, back in maybe a few decades ago, we used to associate heart disease more with men, but
right.
That's changed.
Well, it's very interesting. I had an instructor teach me one time, and when we were looking at risk analysis in patients for cardiac disease, if you take the incidence curve of coronary artery disease, you can actually overlay the curve for men. The women's curve is the same. Mm-hmm. So men and women really don't have a major difference in coronary disease. Mm-hmm. They just displace their curve about 20 years to the right. That is to say, they have the same incidence at only 20 years later, because their female estrogens protect them from the onset of coronary disease. It's sort of like they were taking a medication that protects them from heart attacks. Now, they still get heart attacks in their 40s and 50s if they have severe risk factors, but it's uncommon. The most common age for men to get heart disease is in their 50s and 60s, and women's it's really in their 70s and 80s. So, but women can get premature heart disease, but it's very uncommon unless they have high risk factors like smoking, diabetes, or strong family history. But women do get the same incidence of coronary disease just much later in life.
And just because of the hormone, estrogen.
The protection of hormones. Now, if they have an early hysterectomy, which some women do because of infection or other causes, if they had an early hysterectomy where their ovaries are removed or become dysfunctional at, say, age 20, they become a man. And supplemental hormones have not been shown to be preventive of coronary artery disease. They do prevent osteoporosis, but they don't appear. They're not the same molecules as the indigenous hormones, unfortunately, and they don't seem to have a lot of protective benefit for coronary artery disease, that is to say, oral estrogens.
Wow, that's really interesting. I guess maybe then they may be a better candidate to use things like Lipitor or things to
Are you talking about a person that has premature menopause from hysterectomy or something?
Right.
Yeah, well, again, I think the best advice would be to have an assessment of your family history and your lipid levels. I think that should be done by all adults, really.
Right.
Our lipid levels change when we become adolescents. You might say the same time we get acne, our cholesterol metabolism changes. It's probably due to our male and female hormones. They change our cholesterol metabolism. And so from the time we're adults, we have different cholesterol metabolism than when we're children. And from that point forward, we have normal or abnormal cholesterol metabolism, really dependent on our genetics. And so probably, and I don't know what the pediatricians recommend now, but I think most people recommend that somewhere around the age of 18, maybe about the time they leave the pediatrician, they probably should check their cholesterol and be sure it's not unusually high. Well,
so we know that we both men and women have equal shots of getting cardiovascular disease. Women can buy a few more years, but perhaps if you wouldn't mind maybe talking about some of the surgical solutions. So if you do have a disease, what can be done to improve your odds?
Well, I think that we should always look at that surgery is really always concomitant with medical therapy. It's somewhat foolish to put in, as I say, to put in new pipes and plumbing in people if you don't really change the water.
Right.
People with high incidence of coronary artery disease tend to have bad water. Their body makes too much of the bad cholesterol and not enough of the good cholesterol. And for whatever reason, it's laid down inside their arteries and causes these blockages, which eventuate in heart attacks and heart failure and death. And so whenever we operate on people, we again go back and say they should take statin drugs, they should take aspirin and many other recommendations, and of course a healthy diet and lifestyle, and stop smoking cigarettes if they do smoke cigarettes. So all these are always concomitant. I mean, heart surgery is for this type of thing is not curative. It's a way to correct the problem that's developed over years. But we don't want the problem to come back if at all possible. So
Right.
these medical interventions in terms of various drugs and exercise are very important. And we counsel our patients very strongly on lifestyle modifications, and diet and medications. Now, having said all that, obviously I'm a surgeon and we have surgical approaches. The cardiology profession has various types of interventional cardiology, which are a form of surgery in a sense. They operate on the arteries, you might say, with catheters, which they put in. Most people are familiar with stents now.
Right.
Which a guide wire is advanced usually through the femoral artery, although it can be advanced through the radial artery of the arm, into the coronary artery trees, and pictures are taken to see where the blockages are, and then the blockages are stretched or opened with angioplasty, and then the opening is maintained with a stent of some type. There's both bare metal stents or uncoated stents, and then coated stents where they found out that simple angioplasty had a significant rate of restenosis because the artery would collapse again. The artery, sometimes they can clean the artery out with what's called atherectomy, when they actually, you might say, drill it out. But even so, the artery wants to heal that area by stenosis, and they frequently had stenosis of the narrowing all over again. So then they found that if they put a stent in there, it's a little bit like mining by putting up a roof in a mine so that it doesn't collapse.
Right.
It keeps the wall of the artery from restenosing. But then they found that the body doesn't like to have metal in its arteries, like you could imagine, and it still will form scar tissue right through the stent. So now the stents are coated, many of them, with with drugs that prevent scar tissue around the artery, and so they're so-called coated stents. And there are several different types and drugs, and I think a new one was just released last week by Medtronic, a new type of stent with a different drug. So the technology is still developing of which type of stent, the actual geometry of the stents, the type of metal in the stent, the size of the stent, and then what type of coatings on the stent to try to prevent it from, one, developing scar tissue, and two, getting a clot on it potentially, because your body still wants to clot these somewhat foreign material in your circulation.
Once somebody has had stent surgery, now with the new design of these stents, how long can they expect perhaps that to hold up if they do all the other things right?
Well, it's difficult to say in a given patient. We do know that the coated stents need to be maintained on a antiplatelet drugs for at least a year. We don't sure the data is still being accumulated as to if they need to be on longer than that. Although I think most people recommend people take aspirin almost for life if they have known coronary artery disease.
Right.
Because aspirin is an anticoagulant and affects the platelet.
So they don't necessarily have to remain on Coumadin for the rest of their life?
They're not on Coumadin.
Okay.
Coumadin is not particularly helpful in maintaining patency of stents. It's useful in other forms of cardiovascular disease, but it's never been shown to be particularly helpful in atherosclerosis.
Okay.
But these drugs that do maintain patency are antiplatelet drugs, and there's a number of different ones. Plavix is the most popular and effective drug we have available right now. And aspirin is usually used as well.
Right. Well, we're going to take a quick break just to hear from our sponsors.
Okay.
And when we get back, I was hoping maybe to hear some more about some other surgical procedures as success options for patients.
Sure.
And so we'll be right back after we hear from our sponsors. You're listening to Health View. This is Dr. Angela Ruff. And again, our guest this morning is Dr. Alvin Atkinson.